Yali Madad, everyone. Thank you for joining our webinar today on getting real about drugs, addiction, and mental health. I'm Amina Pradhan, the mental health lead for the Aga Khan Health Board and a neuroscientist who studies pain and addiction. Our speakers today are Dr. Reef Karim, who is a double board-certified physician, humanistic psychiatrist, and addiction specialist, who has worked with royalty, world-renowned politicians, rock stars, A-list celebrities, and the homeless and disenfranchised to better their human experience. Dr. Reef has a mission to break the spell of externalized conformity thinking and self-sabotage, and instead turn up the volume of our soulful and innate expression. He has published in prestigious peer-reviewed medical journals, served as an assistant clinical professor at the UCLA Semel Institute for Neuroscience, and founded, operated, and exited a highly successful mental health, addiction, and personal discovery center in Beverly Hills, California. As a trusted advisor and global expert on the human condition, he has been interviewed by Oprah, Deepak Chopra, CNN, Dr. Phil, Dr. Oz, Today, and Good Morning America. Dr. Shamin Ladhani works as a pain psychologist at Ascension Healthcare Pain Management Center and also runs her own consulting practice, where she conducts independent psychological evaluations, speaking engagements, and provides training for healthcare professionals and the general public. Dr. Faiz Jiwani is an internal medicine primary care physician and medical educator currently practicing in Chicago, Illinois. In his clinic, he partners with patients in medically underserved communities and is active in various aspects of medical advocacy. He also holds a degree in narrative medicine, which is an interdisciplinary field involving the study of literature and the humanities to better understand lived experiences of disease. Just a bit of housekeeping. We will be taking questions from the audience throughout the webinar and will answer them during the discussion. Please enter your questions at any time by clicking on the Q&A button at the bottom of your screen. And with that, please take it away, Reef.
Okay, welcome. First off, before we do anything, I want to applaud whoever pushed this idea to make this happen, to actually talk about taboo topics from the past, to actually talk about the reality of what's happening out in the world and in our community. And I want to applaud you guys for showing up today because, hey, you could be doing anything right now. And instead, you made the decision to learn more about what's happening to humans, what's happening to people in our community, what we can do about it. So applause to you. Yes, I do have sound effects, so you know that's coming. This will not be a typical webinar in any way. This will not be a boring lecture. This will not be something AI could have done on substance abuse or mental health or impulse control disorders, addictions, whatever. Today, we're going to get real. The topic is legit. The title is legit. We're going to get real. So I'm going to start with a little story. So I'm going to Jamat on a Friday night. And, I get there a little late, which, I mean, come on, we've all been there, right? And, I'm trying to sneak in pretty quiet, kind of hide out in the back, walk toward the shoes and put my shoes in the rack really quietly. And I put my shoes in and I turn and this guy is staring at me. And he's staring at me with this like really hardcore, intense stare, like I took his shoe space or I dated his sister in the past, or I don't know. But he's staring at me with this really intense stare. And so I go, okay, that was weird. And then I go inside JK, I do my thing, I pray, all of that. And as I'm walking out, this guy is still staring at me. And he continues to stare at me like he's going to beat me up in the parking lot afterward or something. I don't know what this guy's deal is. So I get my shoes on and I start to walk out and I'm actually a little nervous about this. I'm like, I don't see this guy. I don't know where he is. I don't know what's going on. But you know what? I'm just going to quickly walk to my car and get out of here. So I walk outside and as I'm walking and leaving JK, I hear this rustling sound coming from the bushes outside of JK in Los Angeles. And I'm like, what the heck is that? And I look toward the bushes, and from out of the bushes pops out this intense guy. And he's like, hey, doc. And then he like pops back into the bushes again to camouflage himself. And I'm like, what is going on right now? And then he pops out again. He's like, hey, doc, I got a question for you. And I'm like, okay. And he goes, how do you know you have bipolar disorder? And then he like ducks back into the bushes again. And I don't know what to do. So I'm like, okay, I'm just going to answer this guy's question. And I start talking to this bush, and anyone who's walking around me thinks I'm literally talking to a bush. So like I have the problem as opposed to somebody else. And I'm talking to this bush about what mood disorders are like and how you know you have a mood disorder. Now, why do I tell you this story? I tell it to you because there is a decent amount of stigma out there in the world about mental health and addiction, but there is an insane amount of stigma in our community with fellow Smileys. And we are doing a total disservice to our community members who are struggling because no one is there that they feel they can turn to. They don't know if we have experts in our community. They don't know if people care. And what ends up happening is they feel like, you know, they need to be isolative, and they have loneliness, isolation. They don't talk to their family about it. They don't talk to anyone about it. That is why we're doing this today. It's time to move out of denial and to move into 2024. So this is your reality check. As a community, we can't hide from this any longer. I mean, there are Smileys dealing drugs out of the JK bathroom, out of the JK parking lot. There are Smileys addicted to drugs. There are Smileys going to rehabs. There are Smileys going to hospitals and mental health treatment centers. There's people addicted to behaviors that are ending their marriages because of their behaviors or their mental health conditions or their addictions. People suffering from panic disorders, bipolar, depression, anxiety, schizophrenia, OCD, eating disorders, severe trauma. You know, some Smileys are suicidal. Some have compulsive gambling problems or shopping problems or internet or video game problems. Some are so lonely that you know, they don't know what to do and they feel trapped. The smiling brain is no different than other people's brains. Our community members are suffering, and we don't want them to feel like they have to hide to get the help they need or to be able to talk to someone and to know there are experts out there that can help them. And that's why we're doing this. Okay, so let me start with my definition of mental health. My definition of mental health is a spectrum from the darkest corners of human pathology to the brightest edges of human potential. So what that means is that everything that we've been talking about with pathology is part of mental health. Our darkness, we all have darkness in us. We all have light in us. Our darkness, and that's actually where my background is half black, half white. It's half dark, half light, because that's what we all have. And instead of hiding our darkness, let's acknowledge our darkness. Let's embrace our darkness, because our journey in life for all of us is really to develop purpose, to find more meaning, to do something good for our community, for the world, and to find the light within us, to be more soulfully connected to who we are. And the darkness is part of that, as Jung would say, and as many other philosophers would say. And personal discovery and optimism and life coaching and a lot of the stuff that we see so much more present today in this world of personal development, that is also mental health. That is also part of me being a humanistic psychiatrist. That is what I do. I don't just deal with pathology. I deal with helping people become better in their life. Now, what you will get out of this webinar, you will get a lot of facts about addiction and mental health. You will get an understanding. You will get myself, my two other prestigious panelists, you will get their experience, their life experience and training in everything that we've done. We're going to go over a couple of case studies, either one or two case studies, depending on what time we have. And most importantly, we want to go over your questions. We want to be able to answer as many questions as we possibly can. So please jot down what questions, write in what questions you want to ask. You can ask us anything. And if the question is really provocative and controversial, I'm going to have somebody else answer it. Okay, so we are doing this for you because well over 30%, 20 to 30% of our country, let alone the world, is suffering from mental health conditions. And over 35 million people globally are suffering from addictive disorders. That's a lot of people. Personally, I don't even consider myself a doctor. I consider myself a healer. And part of that healing process is moving people out of pathology and into their potential, into their purpose. And I get asked a lot, why did you go into mental health and addiction? And the reason is because I'm really interested in self-sabotage and how we get in our way. How do we prevent ourselves from having the life we want? So for me, like I said, it's part existential, part philosophical, part psychological, part medical, and it's healing. And to do that, we have to do more of this, more webinars, more podcasts, more television, to be able to deliver messaging in a way that people can hear it. And that's been the shift in my life. Okay, with that, let's talk about 10 things you should know about addiction. And as you see this slide that comes up here, the 10 things you know about addiction, I've got a dark brain that turns into a lit brain, a lit half brain. First off, let's talk about what addiction is. And there's the old school view of addiction, which essentially is a compulsive use of a substance and then later of a behavior to cope, to soothe, to escape from your own reality. And here's the problem with that old definition. It was often thought of as volitional, meaning, hey, just stop it. I'm going to shake it out of you. You know, remember, anybody who's older will remember the expression, just say no. You have the power to just say no. Just do it. Stop it. Okay, enough. Enough. Stop it. No, it doesn't work that way. Whether it's alcohol or cigarettes or cannabis or cocaine or methamphetamine or heroin or prescription drugs or even emerging drugs or party drugs like GHB and kratom and a whole bunch of others, there needs to be a little more than just going, I think I'm going to stop today. Whether it's bottoming out or it's getting a whole lot of support or different types of therapies or different drugs to diminish your limbic system and your craving and a whole bunch of other work. There's a whole bunch of stuff that can be done to help you. It's not just a volitional thing. So then in the late 1980s, all of a sudden, addiction was looked at as a biological problem. Addiction is a brain disease, and it's about hijacking of the reward circuitry that we all have. We all have this natural reward circuitry in our brain from an evolutionary neurobiology perspective to help us propagate the species, which basically means we eat when we're really hungry and it feels good. When we drink when we're really thirsty and that feels good. Sex feels good because we're propagating the species. We're continuing to grow, evolve, and survive. That's why we all have this reward circuitry. What drugs of addiction do, and even some behaviors of addiction, is they hijack this reward circuitry that we already have in our brain innately. And it turns on, especially if you've had some environmental issues, it turns on vulnerabilities and epigenetic responses to you being in a certain environment, which makes you more susceptible to the addiction. And in that world, it's been called a chronic medical disease with complex interactions that involve genetics and environment and an individual's life experiences and brain circuits. The later, more recent look at addiction is addiction at very deeply connected to trauma. Unresolved pain from unresolved trauma leading to compulsive behavior. And a good friend of mine, Gabor Mate, would say, don't ask about the addiction, ask about the pain. What is the pain or the unresolved trauma behind that addiction? So in that case, do a lot of trauma work, compassionate inquiry, body work, in addition to all the different types of therapies and adding medications to the regimen. Personally, now this is me talking, I believe addiction is a spiritual disease or a spiritual chronic disorder, a spiritual condition with biological, psychological, and social elements. We have neuroadaptations that happen biologically. We have environmental stressors. We have psychological issues. We have a deep connection to mental health problems as well in addiction. But a lot of that comes from a disconnection to self. A lot of that comes from a lack of purpose, a lack of belief. And what does a lot of the healing is that reconnection, or you may have never had a connection to self. And it's about that. And like I said, it goes hand in hand with mental health. And the last thing on just general addiction does not discriminate. You could be rich, you could be poor, you could be young, you could be old, you could be a man, a woman, doesn't matter. Addiction is addiction. And you will, if you are susceptible and you have environmental triggers with epigenetic responses, maybe you have the genetic vulnerability, and then you have access to substances, it could happen. Okay, the second thing you should know, technology and mental health. I used to run a treatment center that I had founded and in LA out here, and I was really shocked. We were doing really good work with dual diagnosis or co-occurring disorders, which is a combination of mental health and addiction, or just straight addiction or straight mental health. But I saw something in a lot of our clients that I started to see just in the general public, which was in our clients, people got better. They became free of their addiction, or they were managing it well. Their mental health symptoms were diminishing, but something was happening to them subclinical. They were feeling, especially after social media just hit and AI hit and all these machine learning, a lot of people felt overstimulated. Like their minds felt overstimulated. Like there was too many things to keep track of. There were too many things to learn. There was too much going on. And with that overstimulation came disconnection, decision fatigue, divided attention, deep validation seeking, which is basically getting likes, and on social media comparison, all of that kind of stuff. And there was a dopamine depletion that comes from that. We've all heard of the neurotransmitter dopamine and how it's involved in motivation and feeling good and a bunch of other things. But every time you're getting that spike of like, or the craving of like, because just the anticipation of getting the like spikes your dopamine just like it does getting the like, that spikes and then it falls. And as it falls, you feel like you need another spike just to get up again. And you need that like, and that's where all that craving comes from for that. So what ends up happening is when you have that dopamine depletion and you have that blah feeling, you feel that uninspired feeling, you develop something called cognitive rigidity. And that's where the brain just kind of like shuts down. Everything's kind of like blah and kind of boring and bland. And this is a real problem. And people don't understand that. I'm not saying technology is necessarily bad, but it has effects on our mental health. It has effects on our brain. And then you add the stress of world events and relationships and all that other stuff. The reality is technology is moving faster than our mind's ability to process the technology. That's the best way to put it. And so we have to really understand what we let in. I always say, be the gatekeeper of your own mind. And what you let into your mind is incredibly important. Just like what you eat is incredibly important. What you put into your body, what you put into your mind. You have to become more of a gatekeeper of your own mind. Okay. Third thing to know is the neuroscience of addiction. And on this one, I'm going to keep this slide up because I think it's important to talk about this slide. We constantly have a battle going on in our brain, in all of our brains. And the battle is between our executive function system and our limbic system. And our limbic system is that primal, reward, pleasure-based, impulsive, we got to do it now, we got to do it now, we got to do it now. And the executive is that, wait a second, I don't know if this is a good idea for us. And it's the judgment and the reasoning, and they're constantly going at it in our brain. And usually in healthier people, the frontal lobe will win. And because it wins, we don't always act out on every impulse that we get. So in the neuroscience of addiction, and I added in self-directed neuroplasticity, and once I get off this slide, I'll tell you what that means. you need a certain amount of inhibitory control. And I'm not going to get too scientific, but I know there's some nerds out there. So for those nerds that are out there, I'm speaking specifically to you. The inhibitory control is the prefrontal cortical area and the anterior cingulate area. And you need a certain amount of you need a certain amount of control over your behaviors, over your cravings, your triggers, what you want to do. That area, when it becomes diminished and you have less control and you have a stronger motivation drive, which is some orbital frontal and some other parts of your brain, when it's almost like the gas pedal on a car is jacked and your foot is on the gas pedal, but you're not touching your brake, or your brakes don't work. That's what happens. You have this intense motivation, this decreased inhibitory control, and then you get emotional encoding on your memory. So basically what that means is that you're remembering behaviors and drugs and how they felt in a more pronounced way than the average person. And you have increased reward sensitivity where reward feels that much better. So now if we come off the slide, I can tell you a little bit about self-directed neuroplasticity. So basically, our brains, that's what neuroplastic means. Our brains are plastic, and I call it cognitive flexibility. We have the ability to connect different neurons, to change the way we think, to change the way we behave throughout our life. It's just that we develop habitual patterns, and certain neurons always connect with other neurons, and that's how we solve a problem. Neuron 2 connects with neuron 8. That's how we solve all of our problems. But if we were to be able to connect neuron 2 to neuron 16 or 24 or 40, we would all of a sudden think of the world in a different way. We would think of who we are in a different way. And self-directed neuroplasticity is your ability to become more neuroplastic, your ability to do things that will elevate your cognitive flexibility, doing more creative work, being able to think out of the box by kind of challenging your comfort, your areas of comfort. Meditation can open it up. Deep, like holotropic, deep breathing can open it up. There are many ways we can open up our unconscious, which I'm going to talk to in a little bit, and develop more cognitive flexibility. Okay. Next thing is trauma, adverse childhood experiences. Some of you may have heard of this. Obviously, I've talked deeply about trauma already in the brief time we have. Please look up something called the adverse childhood experiences. These are defined as stressful or traumatic experiences that occur during childhood. And, there's been various studies on this, but, the majority of the studies say that more than 60% of adults, all of us, report having at least one adverse childhood experience. And you can read them here, from physical and sexual and emotional abuse to neglect, to parental mental illness, to parental substance abuse or dependence, incarceration, separation, divorce, domestic violence. Most adults have been through one of them in their childhood. When you get to the point where you have 4 or more of these, your numbers go up significantly, at greater risk for diseases, alcoholism, heart attacks, stroke, depression, diabetes, coronary heart disease, disability due to health status. In fact, adults with any history of these, with at least 3 of them, 3 or 4, have a 4 times higher likelihood of developing a substance use disorder, and a much higher likelihood of developing depression, 4-time likelihood of developing depression. So please check this out. You can come off the slide now. Please check out this adverse childhood experiences and adverse childhood events. And you can just Google it and look it up. One thing that's important to note is when we have trauma in our life, when we have, people call it attachment dysfunction, but just some type of trauma from our childhood, our brain does change. And we have neuroadaptations that also happen with substance abuse and with obesity, where things like CRF and dynorphin and some other things actually change in our brain. Now, the good news is we can change them back. But the bad news is if we don't do anything about that trauma and it's unresolved, it'll stay with us for our life, our lifetime. Okay, next slide. One word is going to describe the deepest problem that we have with addiction. And that word is, can I get a drum roll? That's a pretty poor drum roll, but I'll do it. Shame. Why do people isolate? Why are people so lonely? Why do people have depression and don't do anything about it? When you don't have the life you want and you just sit not content, but sit just kind of not doing anything about it, not creating new opportunities. What is the one word for the problem? Shame. And many people hold shame in the body, so it's not necessarily just in the head. You can have pain in your body, which is actually shame. A pit in your stomach, tension in your shoulders, discomfort on your skin, even itching. Some people will itch, and that could be some element of shame. You can come back to me now. Some common physical cues of shame? A downward gaze, always looking down a lot, not making eye contact, kind of a slumped posture. Pretty obvious stuff, but they can be indicative of depression, shame, poor self-concept, all that stuff. In fMRI studies for shame show, amygdala activation. There's definitely fear. And usually shame presents with an inner critic within us saying something like, you are bad. And then another part of you starts to believe it. And the other thing I want to mention is the difference between guilt and shame. Guilt is, I've done something bad, but it was an act that I was a part of or I did. Versus shame, I am bad. Not I've done something bad, I am bad. I've suddenly identified with the bad. I'm not a good friend. I'm unlovable. I'm a bad person. It's becoming the identity of it. So then the shame just kind of takes over and you don't feel like doing anything. You don't feel like opening up in your life because of shame. Okay, next one, prescription pills. And I know there's going to be some questions, some thoughts on prescription pills. Basically, this slide kind of sums it up. Look, especially in the U.S., if you're living in the U.S., we consume 80% of the world's supply of hydrocodone, which is Norcos, Vicodins, Lortabs. We consume 80% of them. What are we, 4 or 5% of the world population? But 80%, that is an insane number. So if you look at prescription pills, the most commonly abused are called benzodiazepines, Xanax, Ativan, Klonopin, Valium. Those are all in that family. There's a few more. Opiates are most commonly abused. Oxycontin, Vicodins, Norcos, fentanyls, codeine, and there's others. And stimulants are often commonly abused. Adderall being a big one, but also Dexedrine. And I write here that some prescription pills have addictive potential, but a lot don't. But it's not like you should just not take pills. It's just that you need to know, and I will tell you this to the ends of the earth, you need to know what you are putting in your body. Just like you need to know, how many carbs you're putting in your body or how much fat or how much protein you're getting. You need to know what medications you're putting in your body and what they can do to you. Okay, let's go to the next slide. Addiction treatment and the 4 dimensions of addiction treatment. So when you look at addiction treatment, we want to look at it from not just a social perspective. Like, I'm popping pills or doing drugs and it's because I have a marital problem or because I don't like my parents or whatever. There are 4 components that make up how you treat somebody who has a addiction problem, let alone a mental health problem. When I size people up who come to me for consulting or, they want to work with me privately, I look at their biological, their psychological, their social, and their spiritual components. Biological could be like genetics, labs, their reward circuit, medical symptoms, substance use, fatigue, their gut microbiome, sleep, diet, their cytochrome P450 system, and their liver of how they metabolize things. I look at their psychological, their personality traits, their psychiatric disorders, their attachment, developmental history, their trauma, their resilience, their strengths, all that stuff. I look at their social. How are they in their community, their environment, personal history, education, employment, marital, relationships, support, legal, socioeconomic, cultural, sexuality, all of that. I look at their spiritual, their belief system, their faith, their purpose, their passion, their feelings of worthiness or lack of, their self-concept. How do they view themselves in the world? How connected are they in the world? Do they feel like they're protective? They're protected in the world. Okay, next slide is chemical and behavioral addictions. There are things called behavioral addictions. So we all know about chemical addictions, and I named off the most common ones. There are behavioral addictions: gambling, internet, food, sex, fame. At my treatment center, I was the only treatment center in the world. We were written up a number of times in big magazines and publications for treating fame addiction. And I've written a ton of stuff on fame addiction. If you're interested, hit me up on that. But food addiction, sex, porn, work, shopping, video games, all of these massage, or research is showing that they massage the same neurobiology. And for you nerds out there, and you can bring it back to me again, the slide. But for all you nerds out there, it massages the shell of the nucleus accumbens in the reward circuitry, but at a much smaller level than, say, meth. Like meth jacks it up. Cocaine, even cannabis, but at lower levels than, say, cocaine or meth. But food activates that area. Sex activates that area. And if you are genetically vulnerable or environmentally the genes have been turned on, you may have a problem with that, with a behavioral problem. Okay, next slide, vaping. I'm going to get through this fairly quickly, and then we'll finish up and take some questions and talk about case study. So I'm just going to mention a couple facts that have come up. Johns Hopkins wrote a great article on vaping. Essentially, vaping is less harmful than smoking, but it's still not safe, because e-cigarettes heat nicotine, flavorings, and some other chemicals to create an aerosol that you inhale. You're exposed to less toxic chemicals than smoking cigarettes, but you still can get lung injuries from vaping, especially if you do black market liquids or THC vaping products, because there's a vitamin E acetate that's a chemical of concern that's involved in THC vaping. E-cigarettes are just as addictive as traditional cigarettes, so don't think you're suddenly being less addictive. Most people that do e-cigs will just continue to smoke e-cigs with that nicotine. E-cigs are not the best smoking cessation tool. They're just a different delivery system. And e-cigs, because they're, some people think they're cool, younger generation thinks they're cool, they're just introducing nicotine to a different generation. Okay, last two. Psychedelics, and you can come to me first, and then I'll put the slide up. Psychedelics have hit big and have hit hard. And for those of you that are interested in this topic, I know a lot about this topic. From how they were so negatively looked at in the 60s, the 70s, 80s, and even before then. But now there is so much legitimate research on psychedelics for mental health conditions and even for substance conditions for treating them. The AMA has approved CPT coding for coming psychedelic therapies, and one might be coming as early as the end of this year, which I'll talk about in a second. Psychedelic therapy involves a substance. It also, which sometimes is a synthetic compound like an MDMA, and it sometimes is a plant compound like an ayahuasca or psilocybin or something else. And what happens is, the thought behind this is that we have a lot of unresolved unconscious problems, and our fear circuitry, like our amygdala, is so on alert that we can't self-reflect and we can't make major changes in our life because it's so highly activated. And if we can diminish that amygdala-based activation, or if we can explore our unconscious in ways that we couldn't before, we might be able to get at things like intergenerational trauma and things that happened to us in our childhood and things that we blocked or negated. And that's the concept in a very loose, general way behind some of these psychedelics. Psilocybin has been looked at deeply. Again, look at some of the Johns Hopkins studies, and there's a lot of other academic studies for treating smoking, for treating existential anxiety, for treating depression, for treating substance use disorders, alcohol and nicotine primarily. MDMA is probably going to be the first one that's approved for PTSD. MDMA can really decrease the brain's fear response. And there's really good data behind that, which shows, in addition to activating oxytocin and prolactin, two hormones involved with trust and bonding. And there was a Nature article that, looked at, it's called MAPS, MAPS. If you want to look up a lot more on psychedelics, look at some of Johns Hopkins' work and look at MAPS. Just Google MAPS and you'll see. But there was a study that looked at a phase 3 trial on PTSD, and 71% of the people that just did a couple of, introductions to MDMA no longer met diagnostic criteria for PTSD. Ketamine's been out there for a while. Ketamine itself is not FDA approved. A derivative of ketamine called S-ketamine, which you'll find in a nasal spray, has been approved for depression. It's called Spravato. Ketamine is not a perfectly safe drug. It can cause dangerous high blood pressure, slowed breathing. There are all sorts of things. So you need to work with a doctor. And then, LSD is out there, and it can reduce anxiety. You can do self-reflection. And, none of these are perfectly safe. You need to be with somebody who's an expert. You need to have supportive psychotherapy. In addition to it, there's this whole concept of set and setting, where you need to be in the right setting, you need to have the right intention, and you need to have supportive therapy. The last thing I'll say, and then we'll do our case study, is something that I created called States of Rhythm. And I'm going to put up this slide here. In States of Rhythm, it's where are you currently living in your life? So for everyone that's out there that's watching this, or when you watch it online later, we all live in a certain state. And that's why I call it States of Rhythm. There are some people that live in crisis. That is their state. They may not know they're in crisis. They may not feel like they're in crisis, or they may feel like they're in crisis, but they live in crisis. And that involves a lot of amygdala activation, stress, reactivity, impulsivity, a slightly narrow thinking. There's a lot of drama kings, drama queens, a lot of catastrophe thinking, like, oh my God, what if this happened? Oh, I don't know if I can do this. What if that happens? A lot of catastrophe. That's living in crisis. There are some people that live in stabilization. They focus on contentment, comfort, they're risk averse. When they do things, it's for escapism purposes, like watching a lot of Netflix, watching a lot of TV, emotional eating. They feel a little bored. They're all about routine. They're living in stabilization. And there's people that live in growth, and it's hard to live in growth, but you can work at it. And that's what life's about, is trying to live in growth, where people have activated more creativity. They're more cognitively flexible. They're more original in their life experience. They're not functioning as conformists. They're more flexible. They're more connected, not to their environment, where their environment is dictating their decisions, but they're more connected to nature. They have a deeper knowing of self, and they're more connected to self, and they're more curious. So as you can see, there's different neural networks and different brain activities for these specifically. Okay, so now back to me to wrap up here. This is as fast as I could give you 10 really important points involved in mental health and addiction. And, I will say, I've had a big shift in my life from just focusing on being a doctor that is hyper-focused on pathology to becoming somebody who I feel, more, like I said, more of a healer, or more just a person that studies the human condition, that combines existentialism. I combine philosophy and existentialism with psychology and medicine, and even throw in a little entertainment on the delivery system side, because I do a lot of stuff online. I do a lot of stuff in television, because I feel like so many people need to hear these kinds of messages. And again, that's why I applaud the people behind this, the decision makers that wanted to do this. So as I mentioned in the beginning, there are a lot of people out there that are struggling, that are Ismaili, that are in our Jamat, that are part of our community. How do I know this? Because that guy in the bushes was just one of many, many people that have approached me. And I'm sure our other panelists can talk about this as well. We can't just keep this in the bushes. And I'm going to keep using that metaphor because it's funny to me. But we need to bring this out in the open. And we need to talk about this. It is a chronic medical condition, just like asthma is, just like diabetes is, just like hypertension is. Addiction is that. Mental health is that. And it's time that our community caught up. At least let's get to 2020, if not 2024. And, let's talk about this. And hopefully this is the beginning of a much longer conversation about much more support, about much more understanding, much more education, much more time and energy devoted to the topic of addiction, devoted to the topic of mental health. And, myself and my other panelists who are going to talk in a second, we want to be a resource for you guys. So if we can help you, please let us know. Personally, you can hit me up online. You can go to my website, reefkarim.com, and my Instagram at Reef Karim. And also to give you a couple other resources, I mentioned MAPS, MAPS, for psychedelics. Look at the NIH or the NIMH, the National Institute of Mental Health, has some great studies. I look at a couple, I look at some of Harvard's reports, and I look at Johns Hopkins. I look at a couple of others for academics. My background is at UCLA, and they do some great work there as well. Look at the National Institute of Drug Abuse, NIDA.com, and you can look at the SAMHSA website, SAMSHA, the Substance Abuse and Mental Health Services Administration. Okay, with that, we have a case study. So Faiz is going to talk to us about this study, and I got a quick glimpse of it, and it's very interesting, and it's very common. That's the other piece. And then Shamin's going to jump in as well. So Faiz.
All right, thanks, Reef. So happy to share the experience that I had getting to know one of my patients in the clinic. Her name is Samira. She's in her mid-30s. She's a proud mom. She likes sharing pictures of her daughter in elementary school with me during her visits. During our first visit, she had actually scheduled it to talk about back pain. So we began talking about that, how it was limiting her ability to exercise, how it was causing some pain. And then we also talked about how it tended to get worse when she was feeling stressed. And so we shifted conversation a little bit to talk more about what was that experience like and what was going on. She mentioned that she had been looking for a job and that she had been having some difficulty affording food. She had been struggling for a long time with feelings that maybe she wasn't a good mom. And this was something that she really struggled with. And as we continued talking, she mentioned she was having trouble sleeping, that she really just didn't have the motivation to do things in the past that made her feel good, and that she really felt that something was wrong. So through this conversation, it became clear that she met the criteria for a form of depression and an anxiety disorder. And so as we continued to discuss, I asked her sort of how she was managing with these feelings, and how she was managing in general. She mentioned that, she tries to listen to music, but through the conversation, it turns out that she had begun taking prescription medication that one of her friends had been prescribed called Xanax. She'd taken it 1 or 2 at a time at first, and then had slowly progressed to becoming to using 2 or 3 pills a day, which is how much she was taking at the time that we had met. As we talked about this, she acknowledges that this is something that she didn't want to do, and that she wanted to find other ways to cope with this medical condition, and to improve the symptoms of this depression and anxiety disorder that she was feeling. And so we began that conversation. We discussed therapy. I know past some viewers to this event may have heard the ABCs of therapy that have been conducted in the past. And so we made an appointment for her to see the therapist. There was a bit of a wait list at the clinic where I was. And so in the meantime, we had discussed whether a medication might be appropriate for her to help improve the symptoms that she was feeling. And so through that discussion, she expressed an interest in starting a medication. And so we started Lexapro, which belongs to a class of medication called SSRIs that are often used in this condition. And so we continued the conversation. We made an appointment for therapy. I referred her to social work to get some information on nutrition assistance, where the food pantries were, and we make an appointment to come back in about 6 weeks. So at the next appointment, we worked through our pleasantries, and the conversation turns to how she's doing on the medications. And it turns out that after the last appointment, she was wanting to learn more about it, and so went online, had read some things that she'd found pretty discouraging, and so she'd actually decided not to take the medication. And at this point, she was still turning to the Xanax to cope with how she was feeling. And at this point, she had increased her use from about 2 to 3 a day to about 3 to 4 a day. So I'll leave it there. This is the beginning of a series of conversations. But for now, I will pass it back to you, Reef.
Okay, so Faiz, the most important question, what everyone in the audience wants to know. What's the name and which Jamat do they go to?
So
go ahead. Okay, I'm kidding. So some interesting points. And I want to ask you a question, but before that, I just want to mention, please Do not look up WebMD and online forums and make that your health decisions, your mental health decisions, your substance use decisions. Do not go to a doctor, form a relationship with somebody, go to a therapist, just form a relationship with somebody who's a real expert on this, because facts are not experience. The ultimate person, provider, somebody to help you has experience. They have seen what works and what doesn't work, in addition to having the facts. The second thing that's interesting is they had a combination of depression and anxiety. And that very much goes in common. We hear so much about major depression. Major depression, what does that mean? Well, you can also have anxiety with major depression, or an anxiety disorder. An anxiety disorder is just anxiety, right? No, you can have a mood component that goes along with the anxiety. And pain is also involved in depression and anxiety. So Faiz, I want to ask you a question, and then I want to throw it to Shamin. So why is this so common? Like, as a physician, you see this combination of like, maybe difficulty sleeping, maybe a little depression, a little anxiety. They want to take, they kind of trust you. Maybe they take an SSRI, but Xanax is so much better. So they just stay on Xanax. Why is that?
Yeah, it's a great question. And then obviously it's a complex one. Our habits of coping and the directions in which we turn to deal with feelings, whether they're sadness or happiness or even boredom, are conditioned by past experiences, what we've seen in others, and what we've learned to sort of turn to ourselves. In this case, I also want to really highlight that, there's clear evidence that shows that more than 1 in 4 people will experience some form of depression at one point in their life. There's similar statistics available for anxiety. And so in what ways are individuals who may have these conditions and are suffering and may not feel comfortable speaking with others, in what ways are they finding that partnership with a medical professional, with a therapist, to experience their life in a way that with the support that they often need. And so I think that's one major point that I wanted to highlight, and why I think some of these situations are extremely common.
Thank you. That's great. Now, Shamin, first off, if you go to a physician's office, you get, what do you get, 10 minutes now? What is it, 12 minutes, 14 minutes and 32 seconds? What do you get? You don't get a lot of time to get into this kind of stuff, depending on who it is. That's the point of having psychologists and therapists and people that can take an hour to work through stuff. It's also the reason why in our community, there's an access line that we're gonna talk about at the very end. Our community is also stepping up, where you can talk about all sorts of issues in your life and get some help. But especially for what I'm seeing here, you can get help with mental health and addiction or relationships and stuff that's going on in your personal life. So don't be afraid to use it. But Shamin, tell us about 2 things. One, why do you feel like people are not going to the therapist, to the psychologist as much as they should? And 2, give us the scoop on Xanax, because, people need to hear what's going on with Xanax. So tell us your thoughts.
Start with therapy. One of the things I want to say about engaging in mental health treatment is I am a strong proponent of mental health therapy. Any of you have ever attended any of my webinars, I say everyone should be involved in individual therapy once weekly for at least a year of their life, regardless of there being a reason to present. I cannot tell you how much you can expand your mind, your consciousness, your mental wellness without actually engaging in therapy. And I always talk to everybody that I have done therapy, I have recommended therapy, I have had my children try therapy. It is important to be in therapy. It makes me who I am. It allows me to be present with my patients. But I think it comes back to that word shame again, Reef. If we get back to that word shame, there's this long history of stigma. When we look at the history of how mental health is presented, we separated the mind and the body, and that was absolutely the worst thing we could have done, is that this is something scary. It's strange. It's something to be hidden. And our South Asian community, our Smiley community, we are even more involved in sort of that shame spreading, because we often are not comfortable talking about our mental health, or even saying we're on medication, or talking about our depression or anxiety. That is weakness. And we want to stop that right now. And I hope that those of you that are listening right now, if there's anything that you leave from today, that you will feel comfortable talking about it. And I am like, come talk to me anytime. I'm happy to talk to you, whether it's from the bush or straight, directly. I would love to have that conversation. So I think that's a really big thing, is that stigma still exists. Although I feel like stigma is starting to lower the more I talk to people. It's getting a little better. We still got a lot of work to do, but COVID sort of like opened the floodgates. And like now we have like all of these people talking about mental health. We have these shortages and there's no one to access. But we can certainly work on that.
And before we talk about Xanax, and from that, I've heard like in the men's section of Jamat, I heard one guy go, "Hey man, how's your heart? Your heart better? Yeah, is it ticking better now after all that surgery you did?" Like there'll be this scream. I've heard people talk about hemorrhoids in Jamat Khana. "Hey, did you get that worked out? You all right? You all right?" But for somebody to go, "Hey, how's your brain? Hey, how's your mental health?" I don't hear that, but I'll hear everything else that people will talk about. It's like, come on.
Yeah, I agree with that. I wish we can start to have those conversations. And I think maybe because of some of the things I've done, people do come up to me and talk to me about it. But I hope they're talking to each other. I think that's the best thing that we can do, is start to normalize therapy by talking about ourselves being in treatment and making it okay. So let's talk about Xanax. Let's talk about Xanax. So Xanax is probably the most one of the most abused medications that we have. And when I think about Faiz's study that the patient that he was just talking about, this is what we call an immediate coping skill. Like, it's easy, it works fast. We are in this fast-paced environment where I can literally pick up my phone and buy anything I want in a half a second. This is what we want, and this is what we believe that medicine can do for us. Give me something to make me feel better now. So the attractiveness of that is that's what it does. But it has many very dangerous side effects. And coming off of Xanax is one of the hardest things that can happen. If I think about my geriatric population, I have a lot of older adults that are on long-term Xanax and have been on it for 40 plus years. This is no longer clinically indicated, but their physicians are afraid to take them off because of the risk of removing that. But we can safely do it. There are ways for us to do it. And I have seen it done when it is a part of a multimodal process, when we have physicians involved, when we have therapists, counselors, psychologists involved, when we have treatment that sort of elevates that person. I love, Reef, what you've been talking about spirituality and making it human, because I think we have to bring that part and not make it so scary. And when we do treatment that involves multiple levels of care, this is always what I tell people when they come in and I can see that addiction problem starting and they never had that conversation and no one has ever approached them about it. I literally talk to them and say, look, I have some ideas about what we can do, and I have a menu of ideas. Let's talk together about what we can do about this, because I'm concerned for you. You're important to me, and I want you to feel like you can talk to me about this. And even when they leave me, I say, if you change your mind, I am open to you always. Whatever happens, come back to me. If you'd like a different treatment approach, if you fail at this treatment approach, if you have a relapse, I am here. This is not something that I want you to go at it alone. And Xanax is one of those things that we have been seeing used recreationally. We see it used in my pain population that I work with. Many patients use it as a muscle relaxer. It is not indicated for that. So we have a lot of things that have been happening around our prescription drug abuse. But we have a lot of great treatments now. And I love, Reef, what you were talking about with the psychedelics and the psilocybin, because that has me so optimistic about what we can do for addictions. For so long, we didn't have great treatments for addiction, but we are starting to see some amazing things coming for addiction.
Yeah, and doesn't she sound like an amazing therapist, like an amazing psychologist? I think every Smiley should go to you now. And for anything, I'll go to you for something. I'm sure there's something we can work out. On that psychedelic front, I just feel like, look, forget what you call it, whether you call it psychedelics, you call it, just the fact that it's unconscious exploration. We often suppress ourselves. That's called conscious suppression. We're aware. Maybe something doesn't feel safe because we have an idea when we're growing up and we wanted to do something and it didn't feel safe, so we suppress it. Well, suppression eventually turns into an unconscious process called repression. And then suddenly we repress who we are. And then suddenly we develop anxiety or we develop depression. Why? Not just because we have a chemical imbalance, but spiritually, because we're not functioning with our soulful expression in the world. There is a spiritual disconnection to who we are. And I've always been a firm believer that there is a spiritual component to a lot of what we do. And, the other side of that is that, well, hey, if we meditate, if we can get more connected to self, if we can live a more authentic life, and that is a huge word that has, that involves a lot of things, but it's an important thing. And then on the Xanax front, Xanax withdrawal is legit. Like you could get seizures, you can get, Faiz, I'm sure knows all about this and can tell us all about it, but there's a lot of stuff. We have so many questions. I love it. We have so many questions. So what we're going to do, if I could ask Faiz and Shamin, rapid fire. Okay. So instead of, you guys are super knowledgeable about so many things. But we're going to rapid fire this because we have a bunch of questions. So I'm going to try to give it to the right person. If you guys want me to jump in, I can jump in too, but rapid fire. Okay. So I'm going to start, Shamin, I'm going to start with you. Any thoughts on recreational marijuana? Now, it's a loaded question. So what I'm going to preempt it with is not from your personal opinion, but from the opinion of people living in the world that have decided to do recreational marijuana.
So recreational marijuana is a question I get a lot as a pain practitioner because it's also being used for neuropathic pain. And so I am practicing in one state and where it's illegal and one state where it is recreational. So we have a lot of challenges with that use. Now, when we think about recreational cannabis use, it depends on frequency, what the intention is, why you're using it, how often you're using it. Because no matter what substance we're using, as we've been talking about, the different types of drugs that we've been using, the intention of use is something that I always ask about. No matter what someone is presenting to me, my question to them is, are you using it as a coping mechanism for something that you have not worked through? Or is this something that you're using, casually, experimentally, occasionally? There is a difference in how it's being used, but people can often find lots of great internet research that is not appropriate, supports the use of recreational marijuana, that it has no business being used for. For example, when we talk about PTSD, I was working with veterans for a long time. Veterans will often come to me and talk to me about it being the premier treatment, and it really can lead to other obnoxious and very scary side effects, more paranoia, more intrusive thoughts. And so it's not great for things like that.
Okay, great. Thank you. You know what? I should give you some applause. How about that? Okay, Faiz, could you briefly discuss the connection between type 1 diabetes or other chronic conditions like type 1 diabetes and depression?
That's a really great question. The experience of having a chronic condition that requires a significant amount of management, of attention, and that also can definitely have impacts on how you're feeling day to day based on something happening in your body, can definitely relate to the sense of how you feel, right? And so, for example, when someone has a low blood sugar, they may feel, as if they don't have, so then you can have tremors, you can have like dizziness, and you can have these feelings as if you're losing control over your life. And so having that relationship with a provider, with a primary care physician, with an endocrinologist, with individuals who are helping you gain a sense of control, a sense of predictability over your own health is critical for an individual to live a normal life. When individuals who have a medical condition that's not controlled, that's having significant changes on your day-to-day emotions and how you're feeling, it can trigger an individual's tendency to have a mental illness, such as depression or anxiety. So again, these are conversations that you have with a doctor, with a therapist, with your loved ones, with peers, about how is the combination of not just your chronic illness, but food insecurity, housing insecurity, experiences with your peers are affecting your ability to act on your aspirations and live the kind of life you want to live. And when those intentions aren't manifesting, or you're not feeling capable or that personal capacity to follow along those, go to your doctor, go to someone. I'm a primary care doctor, so I like saying, go to your doctor and say, I'm having trouble with this, and I'm feeling like I don't have control, and I want to find ways to feel better. So those are the ways in which I see depression, type 1 diabetes, and other chronic conditions and life experiences as being related.
Great. And I'll add, there is an entire diagnosis and diagnostic system secondary to a generalized medical condition. So in the DSM, you will see, mood disorder secondary to a generalized medical condition, which means you have a mental health issue happening because you have a medical condition happening. So yes, there are definitive connections between cardiac distress, between diabetes, between other things, and having some kind of mental health symptoms, let alone diagnosis. And as you clear up one, you can clear up the other. But they are very chronic, and they are very intertwined in many ways. Not everybody gets them. A percentage of people get them. But it's very important that when you have a chronic medical condition, you make sure you don't have a concomitant mental health, or vice versa. Okay, next question. Shamin, you ready? This is a doozy. You ready? I feel like a game show host right now. I love it. Yes. Okay, I'm going to read this one. It's a good question. I have PTSD and severe anxiety, especially in crowds. Often that's called agoraphobia. And it's difficult to go to JK because it's tiny and super crowded. I'm kind of isolating myself, and I have a lot of people judging and talking about why I'm not coming. Any tips and tricks that can help? I'm a component of therapy, and I'm in therapy now.
Well, the first thing I want to say is thank you so much for that really honest question, because you are not alone, and it is something that is absolutely happening. And I really appreciate that, because Jamat Khana is an overstimulating place, and it can be loud. There's lights, there's people everywhere. And when you come, people are approaching you. And when you have social anxiety, that is the last thing that you want, of course. I also want to applaud you for being in therapy, because that's a really, really important thing. And I don't know what type of therapy you're in. And I don't know if anyone has done our therapy webinar or what was talked about there, but I have to say that when someone has PTSD, there are very specific types of treatments that can work better at getting you to get back to things like Jamat Khana. Because what I'm hearing you say is that you would like to get back to Jamat Khana. And I think that might be important, and that spiritual component might actually help. I am a big proponent of a couple treatments. One is called EMDR. Eye movement desensitization reprocessing. It is a fantastic treatment. Francine Shapiro, it involves bilateral stimulation, and it helps to integrate and kind of heal the brain. It's very cool stuff. If you want to look it up, it's emdria.org. That is a good organization to look at, for emdria.org. I also like prolonged exposure and cognitive processing therapy. So I would be going to your therapist, and I would be asking if they are doing any of these type of treatments, because talk therapy alone is not that great for PTSD. Talk therapy is important, and I don't want to minimize it, but structured treatments actually can target PTSD. I also don't know if you're taking medication. You might be. That may be a good thing to think about, or maybe to meet with a psychiatrist, because the combination of therapy and medication are some of the best options for getting back into existence, life, stepping into Jamat Khana. And prolonged exposure and things like EMDR will work on protocols of getting you to step back in. And it might be good to have like an accountability person, someone that you could go with, someone that could stay with you when you go to Jamat kind of. And maybe you try different times to help with how you're feeling. Maybe morning Jamat kind of is better for you rather than nighttime. And kind of finding some ways to kind of getting yourself slowly back in. Is there a different Jamat kind of you can go to that's a little bit smaller? I know that sometimes we're kind of far away from them. I know that we're not everywhere, but I just want to give you some of those tips as ideas maybe to help you kind of advance your treatment and get you in that space. And who knows, like Reef was talking about, maybe at some point psychedelics are going to be an option for PTSD, because PTSD is very rampant and there's a lot of people struggling. So thank you again for sharing that question with us today.
Yeah, and I've worked with a lot of veterans in the VA, and desensitization is still a really powerful way of doing things. So if you, I don't know if you're doing this with your therapist, but what should I call her? Let's call every single person who asks a question Amina. How about that? Can we do that? Okay, so Amina 1, 2, 3, 4, 5. So that's not her name, by the way, just so everybody knows. It's just the first name that popped up. Desensitization is so if you visualize with your therapist, have your therapist work with you, and you visualize going to JK, you're driving to JK, you're in the car, you're seeing the parking lot full, you're seeing this, you're seeing that, and you go through the entire process and see what's really triggering for you, and you work through that triggering moment. So it's like you're slowing down the whole experience and then going through the very specific elements of it that are so triggering, and you're working through those triggers. But Shamin was great. That was a fantastic answer. Okay, Faiz, you ready? Depression. Do people ever heal from depression? As in, does the black dog, I like the metaphor, does the black dog ever go away? And added to that, how do you help people that feel hopeless?
Yes. People do heal from depression. That everyone's experiences is different. You know, some individuals have a single episode of depression. Others have periods of depression that recur throughout the course of their life. And oftentimes that requires a continuous relationship with a therapist that you check in with regularly. And during periods where the depression is active, that may involve the inclusion of medications, that may include more frequent visits with a therapist. And during other periods, that may involve less frequent check-ins and coming off of those medications. And so this is part of an individual conversation that you have with the primary care doctor, with the therapist, and sometimes a psychiatrist and other people who may be involved. So depression can be a chronic condition that comes and goes as other conditions do, like multiple sclerosis, episodes that people may have from a number of different conditions. And it's also a matter of learning what are those signs when maybe you need more attention, or maybe we need to increase our plan, activate our plan to manage these circumstances. And then, knowing when it's okay to also step back and have a little bit more distance. So absolutely, people heal from depression. People also live with depression or live with a history of depression. And live like very successful and satisfying lives.
Great answer. I didn't give you applause yet, so let's give you some. And I'm sure, Faiz, when somebody comes to you and you decide to put them on an antidepressant, you don't tell them they're going to be on an antidepressant the rest of their life, right? You don't tell them, okay, here it is. You now are taking this pill the rest of your life. It's over. It's done. Like, what do you say to them generally when somebody comes in and you're like, okay, let's try this Lexapro out?
Yeah, so once we enter this conversation about Lexapro, if this is something that the person, after hearing the risks and benefits, wants to try, then the recommendation is you start this medication. It takes a while to work, 4 to 6 weeks for a full effect. And so you have them come back at that point. We'll reassess how you're feeling. If you have some benefit, we'll consider a dose increase. If you have no benefit, we can try another medication that, we can also discuss in the same way. And if you're feeling a lot better, we stay on it for at least 3 months. And at that time, we can reevaluate whether that's a medication you want to maybe try to wean down, or if it's something that you'd want to continue. So at every step of taking a medication, and really any medication, it's a conversation with the person. How are you feeling? What is the impact of this medication? And let's try to find a way that helps you maintain maintain your mental health in a way that allows you to have the quality of life that you're seeking.
And FYI, we've mentioned Lexapro twice. This webinar is not sponsored by Lexapro. Just want to make that really clear for everybody out there. So it's important. He says something really important, which is the goal is not to take a pill and to continue to take a pill. The goal is to utilize the medication in concert with other things that Shamin was just mentioning, like other types of therapies. There's all sorts of other things you can be doing to try to decrease your mood. I mean, there have been good research studies comparing exercise with Zoloft, and they were dead even for the first 90 days, and exercise was even better for long-term diminution of depression, like long-term decreases in mood instability. So there are many ways you can diminish your mood, improve your mood, and diminish your symptoms. If the choice is to be on medications, as Faye said, you might need a short-term dose, you might need an intermediate term, you might need a chronic dose of medications. It just depends. But your depression can absolutely be managed. Okay, I think we've got about, 5 more minutes? If somebody could just kind of tell me how many more minutes we have. Here's a doozy, Shamin. You ready? I like giving you these doozies just because they're interesting. Do you perceive a correlation between mental illness among Ismaili Muslims and a perceived lack of spiritual health and well-being?
I think I'm understanding that question. It's about whether or not mental health is correlated with a lack of spiritual connection.
So specifically for Ismaili Muslims, do you perceive a correlation between mental illness and a perceived lack of spiritual health? So the way I take this question is if somebody perceives that they're lacking in spiritual health, or if they actually are lacking in spiritual health and well-being, does that correlate with having a mental illness or being more vulnerable to a mental illness?
I'm going to say no. I'm going to give a very simple answer, but I'm going to say a couple things about this. And that is that obviously spirituality is a journey, and it's a personal journey, and it's on a continuum. There's not just one way to be connected to God, and not one way to be an Ismaili, and the way that you use your spirituality. And I think we can use it to have hope. I think we can use it to heal. A lot of the studies that look at spirituality in general look at this construct of hope. And hope is such an important thing that we can hold on to that makes us believe that there is always something that we can do. But I want to be really cautious to say that my difficulty getting connected to God or my lack of ability to be connected to God may be directly correlated to mental health issues. There are many people that choose not to believe, and that is something that is a personal choice, and it doesn't necessarily mean that mental illness will come with that. But the benefit of our spirituality is that it gives us an option for coping. And I love how Reef was talking about the biopsychosocial adding the spiritual component, because that's, I think, a piece that sometimes can really enhance and elevate our existence, our intention, our way of living in the world. And I think it can make us feel connected. But I really want to be careful to sort of validate that people can have different belief systems, and that doesn't necessarily mean that would correlate with mental illness.
Okay, great. I'm just going to answer 2 questions really fast. Is there such a thing as addiction to the phone for teens? Okay, there are many rehabs making a ton of money on cell phone addiction, but there is not a true DSM disorder called cell phone addiction. However, what your teens are doing on the cell phone could be internet, like, mindless scrolling on the internet, video games, porn, who knows what. That could be an addiction in itself. And I would ask, why is my teen so focused less on their reality and more on what's happening on their phone? So the escapism element in the phone is saying something, whether it's anxiety or isolation or something else. So there's that. And then the last is, what are your views of harm reduction and meeting people where they are at? So if you're so harm reduction, for those that don't know, means you can. And I was a keynote at one of the big harm reduction conferences at one point, so I know a decent amount about it. Harm reduction is it's not about abstinence. It's not about not using drugs. It's not about not smoking, not using alcohol. None of that. It's about reducing the harm of it, as opposed to not engaging in it at all. In theory, it's good. It sounds good in theory. Hey, let's just take out the harm part of it, but maybe we don't have to not drink anymore or not do this or not do that. In practical use, there are very few people I've seen that have actually been able to pull it off and do it well. I have seen people do it, but I've seen more people that they did it well for a while, had a big stressful problem, a divorce, a breakup, a this, a that, and succumb back to their problem. So, it is what it is. It's better than zero, but I think for a lot of people, they need abstinence. And I think for some people, they can get away with harm reduction. Okay. So to close, we are now closing. There is so much else we could have talked about. Like, there were a bunch more questions. I'm sure Faiz has a lot he could talk about. Shamin has a lot she could talk about. There's more I could talk about. This is a big, big, big topic. We thank you so much for joining us, for being a part of this, for asking your questions. Please continue to talk about this topic in your family, in your community, with your loved ones. It is a very important topic. I've been told a recording of this video will be available in a week or so on the website. And that website is akhb.theasmileyusa.org, akhb.theasmileyusa.org. Please reach out to Access for help. The number is here, 1-844-552-2237. We want the Jamat to know we are here for you for anything, period. Crisis management, relationship issues, whatever it is, we are here for you to help you out. And the last thing is, you'll be asked to complete a survey when this webinar ends. We humbly ask you to take a couple of minutes to complete the survey, as it will help us ensure we bring you important and relevant content in the future. So again, we just like to say from the bottom of our heart, thank you for listening to us, and thank you for allowing us to be a part of your education here and your experience and insight. And please take this experience, insight, and education and go help some people.